Mandibular fracture. Classification of mandibular fracture, Dingman and Natwick anatomy classification. So many classifications are available. This is the basic classification for understanding purpose. So this is the condylar process, and this is coronoid and ramus of the mandible, angle of the mandible, body of the mandible, and this is symphysis and parasymphysis, and this is dentoalveolar process. Mandibular body fracture. Mandible is the most common fractured bone in face. Fracture of the mandibular body on one side and fracture of the condylar neck on the opposite side. Clinical features: swelling and bone tenderness, derangement of the occlusion, premature contact occurs on the distal fragment, fracture between the adjacent teeth tend to cause gingival tears, gross displacement, inferior dental artery may be torn, severe intraoral hemorrhage, sublingual hematoma or ecchymosis in the floor of the mouth. This is called as Coleman sign. It is a specific clinical feature of the body of the mandible fracture. Next, flattened appearance of the lateral aspect of the face and inability to open or close the jaw, and crepitation on palpation. Imaging features: panoramic imaging or CT imaging if the patient is cooperative and conscious. IOP and occlusal images are also taken. Margins of the fracture planes sharply defined, radiolucency lines of separation. There is radiolucent line of separation here. This is the fracture of mandible, and there is a clear radiolucent line between the fracture segments. So margins of the fracture plane sharply defined, radiolucent line of the separation. Displacement of the fragments result in a cortical discontinuity or step or an irregularity in the occlusal plane. So there is a step deformity. It is a very important clinical appearance. Then occasionally the margins of the fracture overlap each other, resulting in an area of increased radio opacity at the fracture site. Non-displaced mandibular fracture may involve one or both buccal and lingual cortical plates. Incomplete fracture involves only one cortical plate. That is, green stick fracture occurs in mostly common in children. Two lines are seen that coverage at the periphery, suggesting two distinct fracture when in reality only one exists. In this case, CT scan or occlusal view would be helpful. This is a OPG showing mandibular fracture. Then we are going for management. Proper reduction is needed. Fixation, immobilization of the fracture bone fragments. Minimally displaced fractures are managed by closed reduction and intermaxillary fixation. More severely displaced fragments may require open reduction. Antibiotic therapy when fracture line involves third molar, severely mobile tooth, or teeth roots exposed in the fracture site. The involved teeth are often extracted to reduce the risk of infection and problem with fixation.